Silicosis has been described as the king of the pneumoconiosis, having been documented as a cause of human disease since ancient times. Silicosis and silica-associated tuberculosis are globally the most common occupational lung diseases and have not been eliminated despite excellent knowledge about how to do this. Moreover, in recent years, silicosis has taken on a new and worrying phase linked to the growing use of high silica content engineered stone, mostly in the kitchen and bathroom countertop industry. Increasingly frequent cases are drawing the attention of clinicians and researchers worldwide, highlighting the urgent need for prevention, early diagnosis, and different healthcare strategies. The Dystopic Silicosis event derived from a seed grant initiative between the University of Padova and Monash University in Melbourne, and offered the chance to bring together different perspectives, combining Italian and Australian experiences.
On the 1st of July 2024, Australia became the first country in the world to ban crystalline silica containing engineered stone. It was determined to be a necessary decision to prevent silicosis, based on extensive scientific evidence gathered since 2015 by respiratory and occupational health experts and a dedicated international government agency. Our research determined that through active screening, 25% of workers who were in the industry prior to 2022 have silicosis. Currently, there have been about 250 people diagnosed with this completely preventable lung disease.
Engineered stone has become an everyday European consumer's product, and countries like Italy and Spain are manufacturing this material in the European Union. Not surprisingly, the world's first cases of artificial stone silicosis were reported in these countries. And in our Veneto region, we noticed a re-emergence of the disease since 2016. One patient died and nearly 30 others have silicosis at various stages. However, these data are not derived from an active screening.
Yes, it is. It affects mainly younger workers and often has an accelerated progression towards progressive massive lung fibrosis, which means an irreversible decline of lung function and a rapid impairment in a patient's quality of life. Beyond the high silica content of engineered stone, the risk may also relate to the cocktail effect in engineered stone dust, including resins and metal oxides. Some of these substances are potentially carcinogenic, pro-inflammatory, and also causes of allergic lung disease.
Because we think that we, as medical doctors, but also politicians and employers, are not sufficiently aware of this new hazard, and this could lead to ineffective risk management and a delayed or misleading diagnosis. That's why me and Professor Hoy have decided to share our geographically distant but similar experiences, mostly with young residents in occupational medicine and pulmonology, but also with occupational physicians in charge of health surveillance of the workers exposed to artificial stone silica. Spreading knowledge is the key for success, and we hope that the meeting struck the nerve.